Antidepressants are actually only proven beyond doubt in moderate to severe depression in conjunction with psychological therapies such as CBT being the best proven one. As CBT is more difficult to access, there can actually be an over-reliance on pharmacotherapy. So NICE advised the generic SSRI as the venlafaxine and TCA are more dangerous than overdoses. Now, the SSRIs, like any antidepressants, they cause the elevation of monoamines within the brain within a number of hours. But the thing is, the effects of the antidepressants aren't noticed until 3 weeks later. So hence, it's due to the fact that there's secondary adaptive changes responsible for the effect of antidepressants. So there's downregulation of beta-1 receptors, of alpha-2 receptors, and also of 5-HT2 receptors. Now, the efficacy of them, 2/3 of patients with severe depression will respond to first-line treatment by 12 weeks. If there isn't a response, first of all, check is the medication being taken as prescribed, and make sure it's taken for at least 1 month. If it is taken as prescribed, the dose could be increased if there's no significant side effects, or else, and if that doesn't work, then another SSRI can be substituted, or else an SNRI can be used. The Maudsley guidelines actually explain how to swap one antidepressant for another. A lot of times there's a washout period required. If they're referred to psychiatry, you often see with psychiatrists they augment the antidepressant with either lithium or antipsychotics. Selective serotonin reuptake inhibitors is actually a misnomer, as not all are selective for serotonin. Citalopram and escitalopram are the only ones that purely act on serotonin. So escitalopram is an S isomer of citalopram, so lower doses can actually achieve the same efficacy as citalopram. At high doses of citalopram and escitalopram, the QT interval can actually be prolonged. So just to be careful with thiazides and domperidone when they're used. Sertraline is safest in cardiac disease, and this was shown by the SAD heart study. Sertraline does not affect the QT interval or does not affect blood pressure, and it's the least likely out of all of the SSRIs to cause sexual dysfunction. Fluoxetine, and this is a weak action on dopamine receptor, which is the drive hormone. So it's actually particularly useful if a patient is apathetic and amotivated. Although it's not beneficial if the patient is agitated or suicidal. So fluoxetine is good if the patient has poor compliance, as the half-life is 24 to 96 hours compared to 15 to 24 hours with the other SSRIs. So with the fluoxetine, it stays in the system for up to 6 weeks after stopping taking it because of the long half-life. The final SSRI is paroxetine, so it has an effect on serotonin and noradrenaline. So noradrenaline is a fight or flight. So a lot of side effects with paroxetine is due to its effect on noradrenaline. There's a number of issues with paroxetine. Number one, the first thing is the fact that it has a short half-life and there's no active metabolite, unlike the other SSRIs. Because of short half-life and no active metabolite, people suffer withdrawal symptoms. And the second issue is the fact there's an increase in suicidality, and it's actually a black box warning in the States associated with paroxetine. And the last one is that it's the biggest offender of sexual dysfunction. The SSRIs tend to have a similar side effect profile. The commonest side effect is the GI side effect, so they can get nausea and diarrhea. And this tends to be most prevalent in the first few days, and then tolerance develops. The one way around this is that they can start with a lower dose and then gradually work up after a number of weeks to a higher dose. Certain SSRIs can have a specific side effect, such as sedation associated with paroxetine and sertraline associated with activation. So some patients who cannot tolerate one may tolerate another. Now, the neurological side effects, so there are a number of there's 4 main neurological side effects. The first one is akathisia, which is basically described, the patient is described as an inner restlessness and feelings of kind of agitation. Dyskinesia, which is an involuntary movement and tremors. Asthenia. So asthenia basically is best described as emotional blunting and decrease in mental energy. And finally, then you've got the anxiety, the dizziness, the headache, and the insomnia, as well as the drowsiness. So those are the main neurological side effects. So then you have dry mouth, blurred vision, and diaphoresis. The more serious side effects are, number one, the GI bleeds. So NICE actually advised a PPI to be given in older people who are on aspirin and an SSRI. They can also cause hyponatremia, especially in elderly patients who present with gastroenteritis, who lose a lot of sodium in their vomitus and diarrhea. Suicidality. So antidepressants in general may increase the risk of suicidality, but untreated depression may also lead to suicidality. So there has to be weighed up the benefit of given an antidepressant in this case. Some SSRIs can cause a prolonged QT interval, so they can get ventricular arrhythmias at higher doses. SNRIs affect both serotonin and noradrenaline. The two SNRIs available are venlafaxine and duloxetine. With venlafaxine, there are a number of things to be careful with. You have to be careful that as it can increase blood pressure, can increase the QT interval, and also increase the pulse. And the most important thing is that it can be toxic actually in overdose, although it's not as toxic as tricyclic antidepressants. Duloxetine itself is also licensed for diabetic neuropathy, and there's another form of duloxetine licensed for stress urinary incontinence. The tricyclic antidepressants were initially tested as antihistamines, but they were found to have mood elevating effects by blocking the reuptake sites for both noradrenaline and 5-HT. So hence they cause an elevated synaptic concentrations of 5-HT and noradrenaline. The side effects associated with tricyclics, there are three main side effects. Number one, antihistamine. Number two, anticholinergic. Number three, antiadrenergic. So the antihistamine effects, there's the H1 receptor antagonist, so drowsiness and weight gain. So the second one, the anticholinergic effects, so it's an M1 receptor antagonist, as they have similar structures to acetylcholine. Can lead to dry mouth, blurred vision. The blurred vision because there's a disturbance of the accommodation, of accommodation, and also they can cause constipation and drowsiness. The anti-adrenergic effects is because that they are alpha-adrenergic receptor antagonists, and this can lead to dizziness and hypertension as well as drowsiness. The TCAs, obviously I mentioned before, they're more toxic in overdose, and like SSRIs, they can actually lower seizure threshold. They're rarely used. The main ones used are dorselapan, which has a strong anticholinergic effects, doxepin, and the related TCA is trazodone. With trazodone, there's actually fewer antimuscarinic and cardiovascular effects, and there's a lower rate of toxicity in overdose. Agomelatine is an agonist at melatonin receptors and an antagonist at 5-HT receptors. It rebalances, by having this effect, it rebalances circadian dysfunction associated with depression. Now, it's particularly useful if the patient has anhedonia, so if they have no joy in life, or if they have anxiety as a primary symptom. There's also a low risk of sexual dysfunction, which is beneficial. The disadvantage is that there's a risk of liver injury, so you have to be very careful if the patient is obese, because if they're obese, they have an increased risk of this non-alcoholic fatty liver disease, and also if they're alcoholics, you should not put a patient on agomelatine if they are alcoholics. The LFTs should be done before treatment and after initiation. So after initiation, LFTs have to be done at 3 weeks, at 6 weeks, at 12 weeks, and then at 24 weeks. And agomelatine should be discontinued if the serum transaminases are greater than 3 times the normal. Mirtazapine is a presynaptic alpha-2 adrenoceptor antagonist. So it blocks this inhibitory alpha-2 autoreceptor, so therefore it's not stimulated. So when it's not stimulated, there's more noradrenaline released, so it increases central noradrenaline transmission. The higher the dose of mirtazapine, the more noradrenaline effect, so the more activating it is. It also blocks 5-HT2 and 5-HT3 receptors, so increases 5-HT neurotransmission.